Yeah, absolutely. Thanks so much for inviting me. It's a pleasure to be here. And yes, I've been interested in xanomeline trospium, otherwise known as CAR-XT, now known by the brand name Cobenfy. Um, I've been following it sort of like pipeline through FDA approval and such. Um, so I actually I thought there was like 15, 20 minutes for didactic. So I actually do have slides if people want to see
Oh,
them.
that was great. If you
Okay.
have slides,
Yeah, yeah,
that's
I do
great.
have
Yeah.
slides. That way
Okay.
we can kind of structure and make sure everyone's on the same page, like structure the
Sure.
it's 15 minutes or 20, it's more likely going to be 20 minutes. So I can do that, and then we can kind of dive right into discussion. I can talk about cases, or you all can talk about cases. But there's plenty of grist for the mill there. So let me just share screen. Okay. So again, just a very, very, very quick background overview, talking about some of the limitations of dopamine blocking antipsychotics. So we have a lot of antipsychotics going all the way back to the 1950s, and all of them, except for Cobenfy, block dopamine. They modulate dopamine neurotransmission by blocking dopamine D2 receptors. And, this is, they are quite effective at many things, but a dopamine blockade, as we know, can be associated with poor tolerability. And this is because, in addition to blocking dopamine in the limbic and mesocortical tract, we know that blockade of the mesocortical tract can lead to exacerbation of negative symptoms. Blockade of nigrostriatal D2 receptors can lead to EPS. And then blockade of the tuberoinfundibular tract can lead to hyperprolactinemia and all of the associated side effects. We also know that dopamine blockade doesn't work for all symptoms of schizophrenia. We know that there are three main symptom domains: positive symptoms, negative symptoms, cognitive impairment. And the typical and atypical antipsychotics are, moderately to very good at blocking or reducing positive symptoms like hallucinations, delusions, disorganized thoughts, and bizarre behavior. But they have only a modest effect on negative symptoms and almost not much effect at all on cognitive impairment. So there are certainly gaps in care there. And then dopamine blockade also doesn't work for all people with schizophrenia. So we know that about 30% of individuals are what we call treatment resistant. And even among those 30%, only a certain subset, about 9%, according to the literature, respond to clozapine. So again, what do we do with this like 21% of individuals who don't respond to anything we have in terms of the non-Cobenfy armamentarium, or even, I shouldn't say that, who just don't respond to the usual medications that we have. So many of the medications that we use block dopamine. However, in addition, atypical antipsychotics, the second generation antipsychotics, except Cobenfy, also block serotonin 5-HT2A receptors. And, this is sort of grounded in the idea of the serotonin hypothesis of schizophrenia, where hallucinogens like LSD are 5-HT2A agonists. And many 5-HT2A antagonists, including atypical antipsychotics, block the psychosis-inducing effects of LSD and LSD-like drugs. However, blocking serotonin, as well as other receptors, also can come with many unintended consequences, including, as we all know, severe metabolic disturbances. So blockade of 5-HT2A and C, as well as histamine receptors and muscarinic receptors, can lead to weight gain and a host of metabolic disturbances, both, by affecting the brain, skeletal muscles, liver, pancreatic cells, adipose tissue, etc. And then, as we all know, antipsychotics, especially clozapine, can have other serious health complications, including neutropenia, cardiac conditions, including myocarditis, and they can lower the seizure risk. The antipsychotics that we have had in our arsenal for the past, 5, 6 decades can be effective, but they do come with a host of serious side effects. And, when people are dealing with this illness, they, have to weigh the risks and benefits. And many people with schizophrenia do stop taking antipsychotic medications. This is a figure from the Katie trial from 2005, which showed that approximately 74% of individuals discontinue their antipsychotic medication over 18 months. So Cobenfy, this is a novel medication. This is a new medication with a novel mechanism. It's a muscarinic modulator that Kesh mentioned was approved in September of 2024. And this is the first medication for schizophrenia that does not directly engage the dopamine D2 receptor. And, there has been a muscarinic hypothesis that goes back, even though most people have not really heard of it. And according to this hypothesis, basically, muscarinic acetylcholine receptors are involved in the pathophysiology of schizophrenia. Muscarinic antagonist blockers can trigger or exacerbate cognitive impairment and psychosis, while muscarinic agonists, those agents that can activate muscarinic receptors, have pro-cognitive and antipsychotic effects. And I find this to be very interesting. So xanomeline, which is the active part of Cobenfy, the brain active part of Cobenfy, is chemically related to an ingredient in betel nut. And betel nut is the fourth widely used drug in the world after nicotine, ethanol, and caffeine. And it's very commonly used in Asia and the Pacific Islands. And this is betel nut here. And many people chew betel nut, and it can lead to this kind of staining of the mouth and teeth. And one of the active ingredients of betel nut is something called ericoline, which is a non-selective muscarinic agonist. And there's actually a paper from 1957 that described the anti-schizophrenic action of ericoline. And there was also a study in 2000 which described that betel chewers with schizophrenia had milder positive and negative symptoms than non-betel nut chewers with schizophrenia. So Cobenfy is a combination treatment consisting of xanomeline and trospium chloride. Xanomeline is the therapeutic component of Cobenfy. It is an agonist that's selective for the M1 and M4 muscarinic receptors. These are acetylcholine receptors, and they activate muscarinic receptors. Xanomeline, in terms of the history, was initially developed by Lilly for cognition in Alzheimer's disease. And there's a paper that you can read from 1997 that describes that study. And they found that it had a pro-cognitive effect, but the problem was that there were serious or difficult to tolerate peripheral cholinergic effects, such as nausea and vomiting. And they also serendipitously found that it had antipsychotic effects. But because of these nausea, vomiting, other GI side effects, they had to shelve it. And the story unfolds, basically with Karuna, the company that developed KarXT, adding something in addition to xanomeline. But the reason why is because xanomeline acts preferentially at M1 and M4 receptors, and these are receptors that are highly localized in the brain. As you can see, this is the brain with anterior cingulate, frontal cortex, caudate, putamen, nucleus accumbens, hippocampus, substantia nigra. And you can see that there are high numbers, high density of M1 and M4 receptors in these regions. But the problem is that M1 and M4 receptors also exist in the periphery. So including in salivary glands, stomach, colon, and these activation of these M1 and M4 receptors in the periphery can result in the GI side effects. So just as a reminder, going back to sort of like med school concepts, procholinergic side effects, there's a mnemonic called sludge, which is a really helpful mnemonic. It's when you have cholinergic crisis signs and symptoms, including sweating and salivation, lacrimation, urination, diarrhea, gastrointestinal cramps and pains, and emesis, those throwing up. These are all the result of overstimulation of cholinergic receptors. So because of these kinds of sludge symptoms, Karuna basically combined Cobenfy with trospium chloride. Trospium is a peripheral muscarinic antagonist. It's a pan-muscarinic blocker, and it's already FDA approved and on the market to treat overactive bladder. The important piece is that it does not cross the blood-brain barrier. And so what you're doing is by adding the trospium to Cobenfy, you are allowing xanomeline to do its action in the brain, while in the periphery, you're blocking the effects of xanomeline so that you are countering the side effects associated with nausea, vomiting, and all the other sludge symptoms that are procholinergic. So it's a little bit similar to Sinemet for Parkinson's disease, where they add levodopa and carbidopa together. And I don't know if this is actually true, but according to one person from Bristol Myers Squibb, they said that, they came up with the name Cobenfy to suggest there's co-benefit of the two medicines together. So just very quickly, in terms of dosing, you start the dose with the lowest dose, which is 50 milligrams of xanomeline with 20 milligrams of trospium, and this is a twice daily medication. And then according to the starter pack, you basically take this low dose for 2 days, and then you can increase to the next step, which is 100 milligrams / 20 milligrams BID for 5 or more days. And then based on tolerability and response, you can increase further to 125 milligrams / 30 milligrams of the trospium. And for geriatric dosing, the maximum recommended is this intermediate dose of 100 milligrams, 20 milligrams twice daily. So the half-life of Cobenfy is actually pretty short. It's about 5 to 6 hours. So this is why it is a twice daily dosed medication. And importantly, it's recommended that Cobenfy is taken on an empty stomach because doing so will minimize the GI side effects. So, I talked about the sludge symptoms that are procholinergic side effects due to the xanomeline, but you also have to remember that because of the trospium, there are also going to be anticholinergic side effects from M1 receptor blockade. So, this is another med school mnemonic that I remember. Red as a beet, flushing, dry as a bone for, causing dry mouth, dry skin, mad as a hatter. People can get confused, delirious, disoriented, blind as a bat. You can have mydriasis with loss of accommodation, hot as a hare, and importantly, it can cause urinary retention and constipation. In fact, the trospium is intending to cause urinary retention for people who have problems with incontinence. Okay, so very quickly in terms of the data that's available, Cobenfy has shown in the published studies antipsychotic efficacy versus placebo. So it reduced the total psychosis symptom severity, the total PAN score. There have been 3 published studies that are randomized controlled trials, a phase 2 trial and 2 phase 3 trials. And as you can see, there was an 11.6 greater reduction with Cobenfy versus placebo. And in the emergent 2 and 3, just slight reduction in that difference, but still significant. And in all 3, there was lower positive symptom severity. There was lower negative symptom severity in emergent 1 and 2. It was not significant in emergent 3. And, we talked at the beginning about how most antipsychotics really are targeting the positive symptoms, but less so the negative symptoms, and really none of them do very much for cognitive symptoms. There was a pooled analysis of the emergent 2 and 3 studies that showed that in the full sample, there's no difference in cognitive effects. There's no difference between placebo versus Cobenfy in the entire sample. However, if you subdivide and do a sub-analysis and look at only people who are impaired at baseline, with i.e. those who have cognitive deficits at baseline, it did show an improvement over 5 weeks, which to me is kind of, it's interesting because 5 weeks is really short, if you think about it, right? So, but they still did find a significant difference for people with impaired cognition at baseline. And Cobenfy has a favorable tolerability profile. So all 3 of the randomized controlled trials showed that there was no significant difference between Cobenfy versus placebo and EPS. There was no difference in weight gain, and there was no difference in prolactin levels. Although this was only assessed in Emergent 2, it was not reported in Emergent 1 or 3. However, as we would expect, based on everything I told you about the way muscarinic receptors work and where they are in the body, Cobenfy does cause greater GI side effects. And there was some evidence of mild, very subtle blood pressure changes as well compared to placebo. So in Emergent 1, 2, and 3, there were differences between placebo and Cobenfy in the proportion of people with constipation, nausea, dyspepsia, vomiting, and hypertension. And the hypertension was like a 3 to 4 point increase, transient increase in the systolic blood pressure. So, just to be clear, those 3 studies, Emergent 1, 2, and 3, they were industry-sponsored. I mean, all of these are industry-sponsored, but that was an industry-sponsored trial, inpatient, only 5 weeks. And you might say, well, that's not very long. Do we have data on what happens beyond 5 weeks? And so Bristol-Myers Squibb also conducted 2 studies, Emergent 4 and 5, that were outpatient, open label. The first one, Emergent 4, is an extension study of the people who completed treatment in Emergent 2 and 3. So people who started on Cobenfy after treatment with placebo, so basically the people who were randomized to Cobenfy continued to take Cobenfy, and the people who had been randomized to placebo were started on Cobenfy in this extension trial. And those people who were switched from placebo to Cobenfy also showed rapid improvement in symptoms, with psychosis severity comparable to the group who started on Cobenfy by week 4. And at the end of the trial, again, 52 weeks, 69% of participants who completed the study achieved 30% or greater improvement in psychosis symptoms. And importantly, there were no new safety or tolerability issues over the 52 weeks. And the results are pretty similar for Emergent 5, which was not an extension study. They newly recruited, individuals with mild to moderate illness with schizophrenia for a 52-week outpatient open label trial. And again, they showed improvements in PANSS total, PANSS positive, PANSS negative, no new safety or tolerability issues, and people reported improved quality of life. From this Emergent 5 study, they did an analysis. I think they also did it for Emergent 4 as well, but I'm just showing you the Emergent 5. This is from a poster that they presented at SIRS, which shows actually that the GI side effects are pretty short-lived for most people. So as you can see here, the procholinergic GI side effects of nausea, vomiting, diarrhea, they are primarily in the first 5 weeks. It's not non-existent, but it's much less in week 6 to 13 and after week 14. So it really is in the initial treatment period that people mostly experience these GI side effects. And in terms of the duration, if you look here, the median duration is not very long. The longest is constipation and dry mouth, a median of 12 days and a median of 38 days. But most of the other symptoms are pretty self-limited. All right, and then what about Cobenfy as an adjunctive antipsychotic? So people may have heard of the results of this because it is unfortunately a little bit disappointing, but this was a press release from Bristol-Myers Squibb in April when they completed their phase 3 ARISE trial. And the ARISE trial was a 6-week double-blind randomized controlled trial comparing Cobenfy plus an atypical antipsychotic with placebo plus atypical antipsychotic. And these were adult outpatients with schizophrenia who had an inadequate response to their current antipsychotic treatment. And the primary outcome was change in PANSS total score from baseline to week 6. And what they found was that their top-line results were negative. So as an adjunctive treatment, Cobenfy did not reach the threshold for statistically significant difference compared to placebo with an atypical antipsychotic. However, I guess it's reassuring, on the other hand, that the safety and tolerability profile as an adjunctive treatment was consistent with previous monotherapy trials. And I think this is important because people, were really struggling with limited data. All the trials had been monotherapy Cobenfy, and they were like, is it safe to add Cobenfy to another antipsychotic? And at least from a safety perspective, there were no new signals. But the story actually is a little bit more nuanced and a little bit more complex. So even though the overall results were negative, they actually did a post-hoc subgroup analysis, which showed that there was a difference in response between people who were on risperidone with Cobenfy compared with people who were on other atypical antipsychotics with Cobenfy. So as you can see here, the p-value is 0.66 for Cobenfy versus placebo with an atypical antipsychotic. So it seems like Cobenfy added no additional benefit beyond risperidone. However, if you were taking a non-risperidone atypical antipsychotic, then there was a significant effect of adding Cobenfy. I'm not sure how to interpret this. I think no one really is sure how to interpret this. Oh, by the way, the non-risperidone group included paliperidone, which is unusual, right? Because paliperidone is a metabolite of risperidone. So like, how does that work? And then there was aripiprazole, ziprasidone, lurasidone, and cariprazine. And it's unclear if the lack of additional benefit in the risperidone group is because some kind of Cobenfy-risperidone drug interaction, or if there's something about the characteristics of people who tend to be treated with risperidone. Maybe, I'm sure they're going to do the analysis, and this is all unpublished as of now, but perhaps, they're individuals who happen to have, more antipsychotic trials previous to this, more treatment resistance. It's unclear. But, you should also note that the antipsychotics that were included do not include all atypical antipsychotics. They excluded clozapine, olanzapine, quetiapine. They included only atypical antipsychotics that were not strongly anticholinergic. And the reason, I think the thinking is that the anticholinergic properties of, say, clozapine or olanzapine or quetiapine would counteract the effects of Cobenfy. So, what would be the purpose of that? So there's still a lot we don't know. How does Cobenfy compare with other antipsychotics? And so, as Dr. Keshavan mentioned, Dos Unger and I, with actually, BI as a site, as well as many other sites, we submitted a proposal to actually study this with PCORI funding, if we can get that, to look at Cobenfy versus other second-generation antipsychotics in early schizophrenia. So there's no information about this. And in fact, we talked to Bristol Myers Squibb to say, if we get this study funded, would you be willing to supply the Cobenfy for us? And they said no, because we don't have the appetite right now to compare Cobenfy with an active comparator. So that study is just not, that data is not available, and I think the drug company doesn't want to do those studies right now. And who are the best candidates for Cobenfy? Is it first episode? Is it more people with treatment resistance? And then how does Cobenfy interact with other antipsychotics, especially clozapine? So as I mentioned, clozapine is strongly anticholinergic. But people may or may not know that clozapine is also a potent and selective M4 receptor agonist. So there are some shared features between Cobenfy and clozapine, which I find really interesting. So those are some of the remaining questions. And I can talk about select cases, or you all can talk about select cases. So I'll just kind of end there and leave it for people to decide how they want to proceed at this point with discussion.
Yeah, let's see who all might have cases among the people who are on the call. And depending on how many are there, maybe we could make a choice to have Dr. Shin go with her cases first. Are there any others, any on this call who might want to bring up a case or two?
It's not about case, but like I can have some question.
A question, yeah.
Yeah, because it seems like based on what you shared and those GI side effects, they at least from the data, it looked like they were short-lived. Did they have a explanation or speculation why?
Why they're short-lived?
Yeah. Why they were seeing that phenomena?
No, I don't actually know. And I feel like I asked that question of someone at Bristol Myers Squibb, and I think I don't know because I never got an answer, or like maybe people don't know, so I'm not sure. I'm not sure. I don't know if it's because I mean, potentially it could be that that the body is sort of like adjusting and compensates, or I don't know if there's something about the pharmacokinetics of like when trospium starts to work better. Those are things I'm just not sure about.
It's interesting, but it's also good to know because like even for SSRIs, that's sort of like a psychoeducation we provide, right? Like you may experience some side effects, but if it is mild level, like usually that goes away after a certain period. So that's interesting that like was short-lived from their observation.
Yeah, and I think that yeah, it's you can tell people that not in everyone, but in most people, it is expected to resolve after, a few weeks. And so I think that helps if people are experiencing nausea and vomiting, that it's not going to be forever. So like, if they can get past that initial stage of the GI side effects, that maybe they can still, stay on the medicine as opposed to having that be the reason they discontinue. Also, you can actually prescribe Zofran, ondansetron, kind of as an as needed medication, and that seems to be quite helpful.
Well, there may be a couple of possibilities. One is that the clinicians might have been making dosage adjustments or using Zofran and thereby diminishing the side effects. The other possibility is whether some level of tolerance might develop to the anticholinergic effects of Cobenfy over the course of time. Even when treating Parkinson's patients, there is tolerance that develops to these drugs over the course of time. So that's a possibility as well.
I have a quick question as well.
Yes,
Go ahead.
Okay. My name is Christine. I'm a PGY3 at Beth Israel. I'm working in the Aspire clinic, which is why I ended up here. So I have heard, and I'm sorry if you already said this, I was on a phone call for part of the time, but I've heard that with a couple of the other antipsychotics, like particularly Seroquel and clozapine, it can be dangerous to do a cross titration where the patient is on both Cobenfy and those medications at the same time because of like intolerable GI effects and potentially dangerous ones. And so that patients will need to be completely titrated off their other antipsychotic before they're put on the Cobenfy and titrated up on that. And I was wondering if you found that to be true in practice, and if so, with these patients who are presumably treatment resistant and very sick and like would be unmedicated in this situation, if that has to be done in an inpatient setting, or if you've seen that successfully be done outside of the hospital and not have people be so destabilized that they end up in a hospital, if you've had any experience with that.
Yeah, that's a great question. So, in my experience, as well as in the experience of people I've seen around McLean, we are seeing that people actually do okay with a combination of Cobenfy and olanzapine, and even Cobenfy and clozapine. You know, you do have to monitor for the anticholinergic burden, because you're kind of, you know, you've got the trospium on board, and then you've got, you know, the anticholinergic properties of olanzapine or clozapine or quetiapine. But I haven't seen anyone get really sick, and it's all been mostly done outpatient. So we haven't necessarily required people to go inpatient. And, you know, for me, I mean, there's very little data on this, so I think everyone's just trying to figure things out, right? Like just by trial and error. And there are a couple considerations. So, you know, you wonder if, you know, you're going to see very much of a Cobenfy effect if you are starting Cobenfy in the context of a medicine like olanzapine, right? Because if it's anticholinergic, then you're kind of, I mean, those are central as well. It's like happening in the brain that those acetylcholine receptors, those muscarinic receptors are being blocked, right? So, you know, what's happening at the pharmacodynamic level, you know, like who's like, is Cobenfy winning that race to get to the receptor, or is Olanzapine, you know what I mean? So it's kind of unclear, like, you know, but you would expect that it would be sort of a blunted Cobenfy effect in the midst of adjunctive, you know, olanzapine or clozapine, but, you know, we don't know. But in terms of safety, there have, you know, I have yet to see any serious safety concerns.
Well, we have a patient in whom standard antipsychotics have not worked, and clozapine also did not work, and ECT did not work as well. And so we are actually considering adding Cobenfy. And in fact, I got some input from some experts in the field, you know, like Herb Meltzer and a couple of others, Rob Laitman in New York. They all suggest using or trying Cobenfy along with clozapine, but one suggestion that came up was, you know, there are two kinds of side effects with Cobenfy and with clozapine, and that is the procholinergic and the anticholinergic. The procholinergic side effects can be better if the person, and I could be getting it wrong, it could be better if the person is taking as advised Cobenfy with food, without food, on an empty stomach. Whereas the anticholinergic effects of trospium could get better if the medicine is taken with food. So it may be a matter of adjusting and a bit of a trial and error to see how we can slow down the release of trospium or the effects of trospium if you are combining clozapine and Cobenfy, for example, and thereby minimize peripheral anticholinergic effects and maximize the central cholinergic effect.
Yeah. I mean, in this context, it might, I will just share my screen again. And there's actually a patient who I could talk about who is on Cobenfy and clozapine together at the moment.
Mm-hmm. Mm-hmm.
And in this case, this is a 34-year-old man with schizophrenia who's had schizophrenia for 8 years, also has OCD and a seizure disorder. Unclear if the seizure disorder is because of clozapine or whether it preceded that. But this person has a very severe illness history with 7 psychiatric hospitalization. He's had trials of ECT for catatonia, and his psychotic symptoms have only been partially responsive to clozapine, 500 milligrams. And the clozapine level most recently was 604, which is high. You know, the reference range, at least for McLean MGB, you know, like it, you know, after you exceed a level of 600, like it turns red, like, you know, it's like high, and you get sort of an error. or not an error, like you get a warning, like that this is a high level. So the symptoms are still there on clozapine, and the person is also protected from seizures with lacosamide, which is an anti-seizure medicine, also seen by neurology for that. And like the outpatient treater really can't go higher. They can't continue to titrate up on clozapine. So what do you do? Where does this person go, right? Like if clozapine is not enough, I showed that pie chart where 30% are quote unquote treatment resistant. And even there, not everyone responds to clozapine. So I think the individual is someone who really is only partially responsive to clozapine. So, we basically added Cobenfy with the starter pack. So started with the 50 milligrams / 20 milligrams of trospium for 2 days, and then had him increase to the 100 milligrams / 20 milligrams BID. And he did develop mild nausea, but that was very responsive to Zofran. And so far, he's doing a little bit better. Overall, I would say that of the cases that I've seen, unfortunately, I have yet to see a very robust response, a robust antipsychotic response from Cobenfy. So my impression, based on just my anecdotal experience, is that Cobenfy will never be it's never going to replace clozapine. It will not be the answer for everybody, especially for people with treatment-resistant schizophrenia. That being said, the idea here is that hopefully we can, by adding Cobenfy, maybe that can provide more antipsychotic coverage to fill the gap that clozapine is not fully able to fill, or so that we can start to come down a little bit on the clozapine dose, because obviously clozapine also is not a benign medicine for this person. He's having tolerability issues with it exacerbating seizures and so forth. So that's this individual. In terms of safety, he's doing fine, other than just mild nausea, which is resolved with Zofran. There haven't been any other safety concerns.
Yeah, so, this is very interesting that you bring up, the patient that I described, I think Megan will recognize who that is. So this patient has a history of significant constipation problem with clozapine.
Okay.
So if we add Cobenfy, we have to be particularly monitoring the constipation problem. And, maybe, of course, he has to get it with food to reduce the trospium effects. We may have to double up on whatever we do for constipation.
Yeah.
But then, the potential advantage might be pharmacodynamically, clozapine has an effect on M4, but not as much on M1, if I remember right. Whereas Cobenfy has an M1 effect and an M4, so it may have an advantage. Yeah.
That's right. So yeah, clozapine is an M4 selective agonist. Cobenfy is M1 and M4 specific. But clozapine also is like probably M1 antagonist. So,
Yeah.
So
that may be an advantage in that sense, to counteract the M1 antagonist effect of clozapine.
Yeah,
With an
potentially.
M1 agonist. Yeah.
Yeah.
So
Yeah, it's hard to know.
It's only a matter of trial and error. We have to figure out what works the best. M4, the role of M4 in psychosis is a bit debatable because the M4 agonist, emraclidine, did not work in schizophrenia.
Yes, it's true.
It was a failure. Yeah.
It was a failure. And, the other difference though with emraclidine though was that it was a positive allosteric modulator.
Yep.
It wasn't a traditional muscarinic agonist.
Right.
So it's unclear like what aspect of it made it fail. hard to-
This patient of mine is from Nepal, country where betel nut is chewed. So maybe he
Mm,
could try chewing some betel nut first
yeah.
and see. Just kidding, but yeah.
Yeah. By the way, speaking of that, so the first case that's listed here is a man who has schizophrenia and is extremely averse to the idea of taking anything synthetic. So like any kind of pharmaceutical product, and actually was amenable to trying Cobenfy because of the fact that it's related to betel nut.
Interesting. Yeah. So how is he doing with that? Is
So
it helping?
it seems to be helping a little bit with perhaps, the parents say clearer thinking, not talking as much about, the delusions around Jesus and such. However, the psychosis is still there. And he continues to have a lot of persecutory thinking around his phone being hacked. He's a little bit guarded. So, the psychosis is not completely addressed by the Cobenfy monotherapy.
Yeah. Yeah.
Just a quick word about some of the contraindications, though, to Cobenfy that I think would probably be worth mentioning. So the contraindications include urinary retention, gastric retention. So I mentioned this because, I don't know to what degree your patient's constipation might be limiting, but, gastric retention, urinary retention, moderate to severe hepatic dysfunction, and untreated narrow angle glaucoma, as well as any kind of previous allergy to trospium or any indication of allergy to xanomeline or Cobenfy. So I think you do have to be really careful about the constipation.
Yep. Yeah, again, taking with food could be protective for the constipation problem.
Yeah, that's interesting. I hadn't heard that about eating it with food. Definitely the procholinergic symptoms are thought to be minimized on an empty stomach. And by empty stomach, it's you shouldn't have food 1 hour before or for 2 hours after taking Cobenfy. I just want to say that in terms of the logistics, that actually is quite a scheduling barrier. Like the questions and the concerns I get from patients and parents actually have a lot to do with just that. First of all, the twice daily dosing is pretty inconvenient for a lot of folks. And then in addition to that, like not being able to take it when you remember or whatnot, you have to be very attentive and mindful of when you eat, when you take your Cobenfy, and then potentially when you take your other medications. They can potentially all be at different times. So it's a little bit inconvenient for people's schedules. I don't know if people had other questions.
Yeah, other experiences. Sarah, Megan, Lynn, and if you are.
I mean, it's not really about case like I mean, it is a case, but but at the same time, I'm noticing this kind of phenomena, like since it is a basically like a breakthrough new type of medication that is approved for schizophrenia, right? And with a different mechanism, I noticed that this phenomena, like some patients' families, they get really interested and fixated on this medication, have expressed strong interest that this is the one that we want to try. Because one of the cases that I ended up like admitting to inpatient was a relatively first, like untreated, unfortunately untreated, a first episode with the prolonged DUP, got complicated with the catatonia in all staff, and parents are very much against about use of because it had some failed medication, failed antipsychotics trial, and the parents were very much against the use of clozapine, Ativan, very high dose, fluctuating here and there, got admitted and then doing treatment, but like really got fixated on Cobenfy, and that's the antipsychotics they wanted to get on, and they didn't want other antipsychotics, especially clozapine. So yeah, because it's not really quite sort of a formed question, but sort of a, you know, something that I've been noticing. Not maybe not to
Yeah,
that.
so I think that speaks to the issue of unrealistic expectations that some of our patients come up with.
Yeah, absolutely. That's like a big challenge. And for people who need clozapine, you know, that can actually serve as a barrier to getting onto clozapine when they need it, right? When it's appropriate. Because as I mentioned, Cobenfy is not going to be the next clozapine. It's not going to replace our best medicine that we have so far for severe illness. And, you know, one of the sort of curbside consult questions that I got a couple months ago was from the inpatient unit on NB2, where, you know, actually just to take a step back, I feel like the cases that I'm seeing, the cases that are coming my way for, you know, questions and consultation around Cobenfy, they're all the sickest patients, you know, and I'm just not sure that this is the medicine for the sickest patients. You know, I really do feel like this is going to be more appropriate. And, you know, like the people who will benefit most are early psychosis folks, right? Who have not had like decades and years of dopamine blockade already, where their brain has molded and like been reshaped to upregulate those dopamine receptors in response to all that dopamine blockade, which is a form of treatment resistance, right? It's like almost like an iatrogenic form of treatment resistance. But so this question came to me from an inpatient attending who gave me this story of a woman who was in her, I think, early 50s, had years, like decades of conservatorship, and had actually been state hospitalized for about 10 years. Been on clozapine, done ECT, like every possible treatment approach that we have in psychiatry, this woman has tried. And the sister moved her from California to Massachusetts, I think, to try to help with the family situation, but got really fixated on Cobenfy being the answer. And it seemed like they were so focused and glommed onto Cobenfy, like, and had almost unrealistic expectations that like somehow the conservatorship, you know, the need for, you know, things like state hospitalization, et cetera, would suddenly just kind of go away with Cobenfy. And so, you know, the approach with that family was to just kind of counsel them that, you know, in some respect that Cobenfy would probably or just delay other forms of treatment that probably would be more appropriate for that individual. So in the end, they didn't end up going on Cobenfy.
And if
Yeah.
I can just say, you really gave an excellent talk here. I couldn't hear the whole thing because I had another meeting, but I just I couldn't help but wonder about Bristol Myers Squibb and their intentions. I mean, it is so important to compare this drug to the other ones we're already using, and not to help you and facilitate this project that you sent to
Yeah, my sense is that
George.
they are there. My sense is that they're worried that it'll not show anything
Yeah,
superior to us. So, you
ex-
know, this is a
exactly.
business. This is a business decision because if you look at the number of points reduction in PANSS scores, it is between 8 to 10. That's exactly the number of points of reduction in any other antipsychotics, including risperidone, olanzapine, and aripiprazole.
Yeah.
So why would it make any big difference? It's so their strategy. If I were to give my thoughts on this, is to look for a subpopulation in psychosis where Cobenfy might have a particular niche. For example, as you pointed out, and in the subgroup with cognitive impairment is where cognition gets better. So it's quite possible that there is a subgroup of psychosis patients who have a muscarinic deficit. In fact, there is neuropathological evidence to support that. That may be the subgroup where Cobenfy has a place.
Mhm.
They
Yeah.
might need to go after a niche like that.
Or
As
first
opposed,
episodes. As Anne
or
mentioned.
even prodromals. Here is another interesting angle. Cobenfy is the only antipsychotic that has been marketed not as an antipsychotic. The word antipsychotic doesn't appear in its marketing. So they were clever about that. And there
Yeah.
are many people in the prodromal state of psychosis who don't want the term antipsychotic. So you could say here is a medicine that could work. It is not a traditional antipsychotic. It doesn't directly work on dopamine receptors. Maybe this will work for you.
But the
That's
other,
an approach.
yeah, that's a good one. But the other aspect, if you focus on the side effects, and the reason patients don't like our current medications is because they gain weight and
Yeah.
all the metabolic effects and the tremors that they get. So,
Right.
you can say that you'll get less side effects with this. And Anne, I'm hoping your study will, that will be one of the secondary things that come out.
Mhm. Yeah.
So let's hope that gets funded.
Yeah. Keep your fingers and toes.
Yeah.
Yeah. Other questions or thoughts from others?
So if you get funded, that's going to be the first head-to-head trial.
That I'm aware of. I mean, yeah. Although, I think that is it Stefan Leucht who is the one who does all the comparative meta-analyses. I imagine that they can very easily and quickly do a comparative meta-analysis using the effect sizes from the 3 published randomized control trials to see how that stacks up against, all the other
I'm sure in a couple of years that will show up.
Yeah.
Simply
Yeah.
based on post-marketing data. So,
Yeah, exactly.
Marketing, yay.
Yeah. And just for you to know, I mean, just the whole concept that Dr. Keshavan mentioned about they're trying not to market it as an antipsychotic. So right now they are launching and or studying at the moment Cobenfy, or they're calling it CAR-XT, right? Because I think Cobenfy will be the medicine for schizophrenia. But CAR-XT is being studied for bipolar mania. It's being studied for Alzheimer's disease. They're going back to Alzheimer's disease to try to get that indication for FDA approval. And I'm sure they're going to try to get as many, hit as many diagnostic categories as they possibly can with this, novel mechanism, basically.
Yeah. Again, I want to thank you, and it was a wonderful teaching. I love your mnemonics.
No,
I
I didn't
you should
invent them. I just learned them in medical school, right?
I'm very fond of mnemonics as well. Yeah.
Well, thank you so
Thanks,
much for
everyone.
the opportunity. Yeah.
So we have recorded your this discussion, so Lynn will be able to send that to you.
Yeah, I'll share you so
And
you
I'll-
can see the first half.
Yeah.
And feel free to reach out if you have additional questions that come up after this meeting.
Okay. All right. Thanks, everyone.
Yeah, thanks everyone.